Okay. So today I will be presenting about the essential role of clinical pharmacologist in hospital. What actually they play a vital role. Actually, they are playing a vital role in optimizing the basic medications which are being used in a multi-speciality hospitals in everyday day-to-day life. And since we are emerging as a developing country, so we are having here a many significant roles in healthcare. We are having a basic impacting role in having a significant role to impact a particular medical background. So we are having a basics requirement which we are providing to the medical services as a clinical pharmacologist department in a healthcare setup. So the basic setup which we are as a PharmD, doctor of pharmacy, what we are providing are prescription assessment. So everybody know that prescription. What is a prescription? So basic prescription, we all know that what a doctor writes for a particular patient about his complaints, his chief complaints. So how we can particularly we play a vital role in collaborating with physicians to assess that particular prescription. So in that we are playing that role as clinical pharmacologist. We carefully evaluate these medications which are being prescribed by doctors to ensure that each patient receives the right dose of particular right drug. For this, I just want to give a particular example. Like if anybody has been prescribed as sublingual nitroglycerin, so particular that medicine is for chest pain, so that must be written as like sublingual. It must be written on that prescription also. So that particular patient also knows that he has to keep that in his mouth for 10 to 15 minutes and have to lay down, and by sitting position he has to take that particular medicine. So that we can ensure by this we can ensure the maximum efficacy and minimum adverse effect of particular IPD prescription or OPD prescription audits. And yes, this here we come the main role, that collaboration with a particular physician. By collaborating with physicians, it makes a tailored therapeutic plans that help patients to achieve the best outcome that can be reached by collaborating with physician only. So here our role is very much basic and very much important for particular patient to for his overall therapeutic plan to be accessed by from doctor side also, and by improving their particular health chart by seeing their drug chart. So here what we can do, here we can assess that medication error. So what is the basic definition of medication error? It is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of healthcare professional, patient or consumer, according to National Coordinating Council for Medication Error Reporting and Prevention. This is what which every hospitals nowadays follow. Every NABH hospital, particularly every NABH hospital works on any particular guideline. So if they are seeing that particular guideline for medication error, they will be seeing NCC MERP guideline. And according to that, mainly three types of errors are defined, in which first error is prescription error, in which any type of irrational, inappropriate, and ineffective prescribing, under prescribing, over prescribing by a particular doctors from doctor, since any kind of irrational, inappropriate, ineffective prescribing has been done, which can be like illegible handwriting also, which can be seen in prescription error. And then comes the next indenting error, where any types of wrong notification order being given by healthcare professional like nurse to the dispensing pharmacist for any order which they place for inpatients which are being admitted at the particular hospital. For any patient, if they order any wrong medicine which they might have known, but like a Lassa drugs look alike, sound alike, and those types of drugs, if they order like in same name, then it can be an indenting error. So that we can see here. And from dispensing error, from also from pharmacist, in if any kind of formulation which are being dispensed, which are like wrong drug, wrong formulation, wrong label, that particular Lassa drugs only, Lassa and Saba drugs sound alike drugs. So we can see that also. And here comes what is NCC MERP harm scale. So particularly National Coordinating Council for Medication Error Reporting and Prevention harm scale is used to categorize the medication error according to level of harm they cause to the patient. So here we mainly see the particular level of harm which has been created for particular medication error which has been happened, and we categorize them in like 9 points. We are having 9 points which are starts from particularly from A to I, in which A being the least harmful, less harmful, and I being the most harmful, which that condition can also be particular death of particular patient. So, NCCMARP scale is mostly used by healthcare professionals to assess the severity of any medication error that has been taken, and for that, appropriate action has to be taken to prevent harm to the patient in further more future cases. For future cases, the scale is also used to identify areas for improvement in medication safety and to monitor trends in medication errors over time. So this is particular NCC-MERP index which is being followed nowadays. Uh, so first of all, category A, where circumstances or events that have capacity to cause error, particularly any circumstance for like any particular illegible handwriting, any wrong medication provided, that all can be categorized under category A. Then we move to category B. The error occurred, but the error did not reach to the patient. An error or for omission does reach the patient, like any omitted error from illegible handwriting or particularly one word missing error of particular prescribed drug, that can be seen in category B, C, and D, which are less to be harmed, which may need any type of intervention or intervention for particular monitoring can be needed for those errors. And then comes category E, F, G, H. In this particular error, mostly intervention must be made by a particular healthcare. Any healthcare can make this intervention. And next, further, the intervention necessary to sustain life, like CPR, defibrillation, intubation, which are basic emergency care, which we will provide if the patient have particular medication error regarding category I, where it can be life threatening to the particular patient also. And then in particular prescription audit, if we want to minimize that those errors through screening like prescriptions, clinical pharmacologists detected any mistakes or inconsistency by seeing that particular two medications which are of same generic but prescribed by two doctors with other names like tablet patch and sildenafil. They both are the brand names, but they both contain the same generic sildenafil. And we can also see that particular drug like sildenafil, if it is has been prescribed, it must be prescribed according to the time which has to be maintained. Like if it has been it's mostly given for patient for to awake that patient for whole day, but if it has been given at night, so it's of no use for night, because if at night the patient has to sleep. So we have to see that also, that particular time has been maintained for that particular drug or not. And other functions also as clinical pharmacologist team perform induce included like dose calculation, dosage regimen check, ADR identification and management. And in ICU care, it's mainly we mainly perform any type of error like if happen while doing any drug constituent, while we maintain concentration of any drug like fentanyl concentration, atracurium, Nevoc, noradrenaline. If a particular patient is having low BP, sudden low BP, so NORAD will be given. So it can't be given directly because its concentration is very high. It's so it must be diluted with like 5 milli, 5 ds or NS dextrose or NS normal saline with this particular guideline. So it must be seen, and particular medicine has to be reconstituted and then only given to the particular patient. Then monitoring of adverse drug reaction and adverse drug event. If any patient we see have a prevention to detect any management of adverse drug reaction to ensure that patient safety has been maintained, and particular reporting of that has to be also be done from utilize that particular ADR reaction, and any potential root cause we have to identify that also. that what is the particular root cause analysis. We here do a particular root cause analysis, and particularly corrective and preventive action for that particular drug, that is called kappa action, which we take for particular ADR which has been reported. So if any ADR has been detected, it must be first filled the a particular ADR form, and then we can report and document it, and what are the particularly root cause analysis of that particular drug from which has been done. So it must be returned to that particular pharmacist, and particular documentation from pharmacist in also it has to be done from inpatient pharmacy. And then in our ward round participation, we hereby perform a very crucial role as a medical professional to hospitals in patients at their bedside to review and follow up their progress in their health, like particular medication if any it has been prescribed in inpatient chart, then what was the particular effect it has shown in a particular 2 to 3 days of period. So we can see that time, because that particular time is not being assigned by particular patient, by not by particular doctor of that patient, because doctor visit is like mostly for 15 to 20 minutes per day in inpatient, because they have to also see a particular doctor also have to see that more patients in OPD. So if they will come for 15 to 20 minutes, say, at that time they will only see the particular chart of their progress and normal what are benefits has been given. But as a whole day, if we are going in ICU and any other healthcare in general wards, we can see those things like particular what type of if the medication is given, is it if affects that particular person or not, any kind of adverse effect is seen or not, any kind of progression progressive it has shown, then that also we can note in that chart. So, involvement of clinical pharmacology in ward round is various clinical settings contributes the promotion of responsible drug use, enhance patient care, shortens the patient hospital stays. And here comes our next role, like narcotic audits and its vigilance. So, narcotics is a very crucial drug dispensing, and it is a very crucial. Like in every hospital nowadays, fentanyl drug is mostly used by anesthesiast. So its proper storage has to be seen. Like it must be narcotics must be handled by a particular person of IPD pharmacy, inpatient pharmacy. Any particular one person has to handle that narcotics. So if he handles, he must maintain a particular register of how many requisition he received from particular doctor, any doctor of the department, and how much this has that particular medicine has been dispensed to that doctor and particular department, if particular department required, which uh, has ordered that particular narcotics from the IPD, inpatient pharmacy. So he must maintain a particular record, and particular storage has to be seen by him only, that according to that only he has dispensed. And spillage policy, there maintains a spillage policy. If see particular fentanyl has a suppose if particular fentanyl packet have 10 drugs, so that 10 drugs is how much used and how much vials has been returned back to that particular IP pharmacy. So from that we can see that how much drug has been used and how much drug has been carefully used to the particular patient. If any drug has been spilled, then particular that nurse or from nurses in or from pharmacy in, if it has been spilled, so we will have to have also one form for that also, to check that particular spillage narcotics drug, and we will be degrading as per the narcotics drugs policy at last in front of drug inspector in last month. Every month there is a particular audit of narcotics in which drug inspector comes and inspect how much particular vial has been utilized in particular hospital setting, and the cut vials of that particular medicine. If suppose if fentanyl is there, then every cut vial of that fentanyl will be disposed in front of the drug inspector and the higher authorities of particular PTC committee. Every hospital has that PTC committee Pharmacy and Therapeutic Committee that will that will check that particularly inventory and also all the drug spillage and all the requisition forms, that form H also, uh, for particular requisition which is being maintained and has been allotted to particular patient. By this we are having a particularly role have a great role in that narcotics department and its particular vigilance. And then use of restricted antibiotics usage. Restricted antibiotics are usual practice in Indian scenario. It is commonly practiced, which includes usage of high-end antibiotics without understanding the metabolic dynamics of the subject, including aggressive of the antigen, antibiotic sensitivity, etc. During such malpractices, the patient develops resistance to the specific antibiotic or at times get carried towards antibiotic-induced toxicity. Like for example, Tazar, a popular brand which contains a generic as piperacillin and tazobactam, that can induce a leukopenia, like decrease in leukocytes, infrequently associated with prolonged therapy of more than 21 days. If that particular medicine is given more than 21 days of no use for particular patient in ICU setting also, then this can lead to decrease his leukocytes count, and ultimately it can also provide a particular patient of resistance from that particular drug, and it can be also seen from antibiotic sensitivity testing, which we can which in most of the hospital it has in micro we are doing performing a sensitivity testing. In that also, if particular suppose a organism like E. coli, it can be detected like it has been sensitive to most of the drugs which are being used, which I am explaining in next slide also, in like a antimicrobial stewardship program, which we basically perform in every hospital setting. In this, we will see like from starting, we will see like evaluating the patient's clinical condition according to symptoms, medical history, determining if antibiotics are given based on the clinical presentation, uh, that a particular patient, if he has been allotted a particular antibiotic, so we will first see his symptoms and then medical history for according to that, is he been taking that medication earlier also or first time he is being prescribed, and then initial antibiotic selection we will do. And for that we will be using that empiric antibiotics, which mostly like causative pathogens for the specific infection, consider local resistant pattern and guidelines. First of all, we will be starting a high-end antibiotics, which will have a role, or which will have a, great role on both the types of organisms, like gram positive also and gram negative also. So, firstly, if any physician starts for drug antibiotic, he will start from like Tazar, Meropenem, tetracycline, and most probably that ceftriaxone and sulbactam. This combination is mostly used because these drugs are being used for both gram positive bacteria also and gram negative also. And after 1 day, there will be culture collection in morning time, in mostly in patient setting. There will be urine, from urine also urinary tract infection we can detect, sputum also from for respiratory infections, for blood from blood like sepsis and other sites also for clinical presentation. And then laboratory processings can be done and microbiology lab, and there we can see that particular if any sample like urine sample has been taken, so from there we can see that particular sensitivity testing of that particular bacteria or particular organism can be seen, and then initial empiric therapy can be maintained according to that, only according to that antimicrobial resistance testing page which we get from that microbiology lab. And then according to that only we will be starting the laboratory performing sensitivity testing to determine which antibiotics to be identified microorganisms are susceptible to. For that only we are performing that AST test, antimicrobial and sensitivity testing. And if in antimicrobial sensitivity testing, if particular drug has been shown susceptible or means it has sensitivity, then particular sensitivity drugs we will be only giving. rather than those showing resistance, because that will be of no use for that particular patient. So for that only we will be doing antibiotic adjustment. If he is showing resistance towards any drug like meropenem or uh, piperacillin, uh, piperacillin tazobactam combination tazar, then we can change that. We can escalate or de-escalate according to that only. Which this lines means that if patient condition improves, the culture indicates a more narrow spectrum antibiotic is effective. Switch to that antibiotic. In this escalation and escalation process is like, first of all, we have given that particular antibiotic on first day in ICU setting. If next day we are having that our EST antimicrobial sensitivity testing report, according to that we can also escalate or escalate that particular drug. And after that we have escalated that drug or de-escalated or continued that drug for 3 to 4 days, then again we will be sending that uh, EST for EST again, and then again we will be seeing that particular drug has shown any effect or not, uh, and is there any scope of escalation or de-escalation. Escalation means that we will be shifting towards higher end antibiotics more, and disclasion means is where his condition has been improved, we will be shifting towards less effective, less means effective towards gram positive and gram negative bacteria, less antibiotics we will be shifting from less. That is called de-escalation. According to patient condition we can see we have to do this, and according to that only we have to monitoring and follow up. This is very crucial step in monitoring every patient in clinical setting like ICU and cardiac ICU. And new antibiotic regimen we will follow according to that only, and adjust therapy as needed based on clinical improvement and adverse drug effect if seen or sensitivity results. And according to that only duration optimization will be evaluated of the particular patient, and then review evaluation of particular patient's safety. And if it has been improved, patient has been improved from particular antibiotics, then we can slowly we can discontinue that particular drug from the particular patient's bedside. And then particular documentation and communication has to be maintained with particular physician, pharmacist, and nurses also, according to the antibiotic decisions like culture results and changes in therapy. And again we have to all we have to like feedback and education to particular healthcare for particular antibiotics usage. And this whole antimicrobial stewardship which I have explained is from reference I have taken from that is Stanford guidelines, USA, that Stanford guidelines which I have shared also in PPT. Yes sir. So sir, any question?